So think about your last trip to the pharmacy. You paid your $20 copay, but did that mean your medication was actually inexpensive? Or is that low cost just an illusion, kind of hiding a massive financial machine operating right under our noses?
Welcome to Embracing My Vitality, our educational series on the prescription price game. Because a low copay can absolutely hide a high price, and we're going to look at exactly how the system shifts both cost and control right back onto patients.
You know the drill. At the counter, you hand over a $20 copay and leave feeling like the insurance system worked exactly as it should. The upfront expense is totally manageable. But here's the thing, that is strictly the patient view. What remains completely hidden from us is that hundreds, sometimes even thousands of dollars are shifting around behind the scenes. The insurer pays its share, employers finance part of the plan, and public programs bring taxpayers, like you and me, into the chain. All these rebates and administrative fees keep moving money around long after you've actually taken your prescription home.
Now look, healthcare has real costs, and professionals absolutely deserve fair compensation. But the real problem kicks in when one single prescription generates revenue for literally every single link in the healthcare chain. We're talking manufacturers, wholesalers, insurers, pharmacy benefit managers or PBMs, pharmacies, and even the investors backing them. Every single organization involved is looking at margins, contracts, and future earnings. So the big takeaway here? Every link becomes an opportunity to maximize revenue, and that happens without necessarily improving your care, your affordability, or your access to the medicine.
So what does this all mean for the actual price? Well, the anatomy of a drug price is incredibly complex. A single medicine can carry several conflicting prices all at the exact same time. The manufacturer sets a list price, but the pharmacy pays an acquisition cost. You might see a cash price, while your health plan pays an insured reimbursement. Then there is your patient cost sharing, which is your copay or deductible, and finally the net cost, which is what remains after all the rebates are settled. It's like a giant puzzle. The crucial point for us is that these figures are not interchangeable. A low copay simply does not prove that a medicine was inexpensive. It often just means the bulk of the cost was quietly shifted somewhere else.
Let's transition into when cost becomes control. This is how the system manages those high underlying prices.
As drug spending rises basically across the board, payers naturally look for ways to contain it, right? But that financial pressure transforms into these heavy gatekeeping tactics. We see prior authorizations, step therapy, where you're actually required to try a lower-cost option first, quantity limits, highly restrictive formularies, or even mandatory specialty pharmacies. And sure, while some of these do serve legitimate safety purposes, when high underlying prices create the crisis in the first place, these access controls often just become a really harsh substitute for actually fixing the price itself.
The deeper issue here is understanding who is actually enforcing these controls. Financial incentives run deep through every stage of care. When an insurer, a PBM, and a pharmacy share corporate ownership, which happens a lot, they can profit at multiple stages of your single prescription's journey. So keep this in mind. Different logos on your health cards or at the pharmacy counter do not necessarily mean independent economic interests. They are often part of the exact same whole shebang. And because of these interlocking incentives and access controls, a pretty startling reality emerges. You can have valid insurance, a doctor's prescription, and a genuine, undisputed medical need, yet still face massive delays, coverage denials, or completely unaffordable out-of-pocket costs. Basically, you might be insured on paper, but you are definitely not always protected in practice.
Let's look at a really concrete example to put the scale of this into perspective. $177. According to a Federal Trade Commission staff report, this was the average acquisition cost for pharmacies to obtain dimethyl fumarate. That's a specialty generic medicine used to treat multiple sclerosis based on 2022 commercial claims. Okay, so the pharmacy paid about $177 to acquire it. But get this, affiliated pharmacies were paid roughly $3,930 for a 30-day supply. No way, right? That exposes a massive average markup of over $3,700 that the system just absorbs.
And this is definitely not an isolated finding. That exact same FTC report examined tadalafil, which is used for pulmonary hypertension. The average acquisition cost was just about $27, yet affiliated pharmacies were paid approximately $2,106 for a 30-day supply. Literally a $27 cost ballooning into a $2,000 payment. Now, the FTC report also looked at insulin, and this brings us to an absolutely crucial dynamic regarding rebates. The staff alleged that large PBMs actually favored products with high list prices and large rebates over lower list price alternatives. The concern here is pretty clear. A system that actively rewards larger rebates can actually give manufacturers a reason to compete by setting higher starting prices instead of just offering lower prices at the point of sale.
So what do we do about it? Let's talk about navigating the system and exposing these hidden costs and access barriers early.
Look, we know you can't single-handedly redesign the entire healthcare system from the pharmacy counter, but you can absolutely take some highly actionable steps. First, always compare the insured price with a legitimate cash price. Remember, your insurance is not automatically the cheapest route. Second, try to check for prior authorizations or step therapy requirements early, so you know the rules and can prevent major treatment delays later on. And third, sit down and discuss medically appropriate alternatives with your prescriber or pharmacist. Ultimately, the goal is getting you effective treatment at a sustainable cost.
And if you do face a hurdle, keep this one key action in mind. Always request the reason for a coverage denial in writing, and then ask about an exception or an appeal process. A coverage denial from your insurance is not always the final decision, so don't be afraid to push back. As we wrap up this explainer, we can clearly see that a manageable copay can often conceal a highly unsustainable transaction. So I want to leave you with this question to really think about. Who really profits from the exchange, and who actually carries the burden when the price becomes unsustainable?
By the way, these wider relationships between money, institutions, and medical care are developed further in our books, Embracing My Vitality, Living Well in the Modern World, and Living Well Without Diabetes, a practical approach to glucose control. Both are available worldwide on Amazon if you want to dive a little deeper.
Help raise awareness by reposting this clip.
www.embracingmyvitality.com